Good morning, everyone. I would like to thank Dr. Nag and Dr. Gupta for giving me this opportunity to present two interesting abstracts. The first abstract is primary radiotherapy and DIEP, or deep inferior epigastric perforator flap reconstruction for patients with breast cancer. The PRADA study, it is a multicentric prospective non-randomized feasibility study published in the Lancet in May 2022. It was conducted at 2 NHS hospitals in the UK. So we all know that post-mastectomy RT is given after surgery always. But in this study, the feasibility of preoperative RT was explored. Breast construction followed by radiotherapy is a challenge sometimes because of adverse effects like flap contracture, fat necrosis, and flap failure. And also there are delays in starting adjuvant RT after immediate breast reconstruction because of wound complications. So women above the age of 18 years in whom post-mastectomy RT was predicted to require and were suitable for DIEP flap reconstruction were included, a total of 33 women. The sequence of treatment was neoadjuvant chemotherapy followed by preoperative RT followed by surgery. All patients were treated with hypofractionation regimes, either 40 gray in 15 fractions or 42.7 gray in 16 fractions. The primary endpoint was open wound more than 1 centimeter at the end of 4 weeks post-surgery, requiring dressing or packing. The secondary endpoints were open wounds at 8 and 12 weeks after surgery, flap failures, and patient-reported satisfactions based on a questionnaire. So open wound more than 1 centimeter was seen in 4 patients out of 33 at the end of 4 weeks and 8 weeks post-surgery, and none at 12 weeks post-surgery. There were no flap failures. The patient-reported satisfaction scores increased from baseline to 12 months, from 48 to 73 to 77 at 12 months post-surgery. The pathological complete response was seen in 7 out of 33 patients. After a median follow-up of 23.6 months, there were no locoregional recurrences. So this method of delivering RT before surgery is technically feasible and safe. The interval between radiotherapy and surgery is important. It should be at least 4 weeks so as to allow settling in of acute reactions due to RT, and not more than 6 weeks so that fibrosis doesn't set in. Something encouraging about this study was that no locoregional recurrences were seen, although many patients had a high-risk disease, that is T3, T4, or node positive. The study is limited by small patient numbers. Further, we require a randomized trial comparing preoperative versus post-mastectomy radiotherapy in patients who have undergone breast reconstruction, and specifically the oncological outcomes need to be compared. I came across another study which is targeting specifically DIEP flap reconstruction patients, which was published later in the year. This is a retrospective study comparing late toxicities, and toxicities were significantly higher in the post-mastectomy RT arm compared to the neoadjuvant RT arm. So unlike other sites like rectum, esophagus, the aim of preoperative RT here is not to shrink the tumor so that it becomes easy for the surgeon to operate, but it is to preserve the benefits of autologous breast reconstruction. DIEP flap has been shown to have superior aesthetic outcomes compared to other methods of reconstruction. So these benefits are preserved when we give preoperative RT. It is safe, immediate breast reconstruction is possible, and additional surgeries can be avoided. The second abstract is a phase 2 randomized trial comparing conventional versus hypofractionated post-mastectomy proton radiotherapy, presented by Dr. Robert Mutter at the San Antonio Breast Cancer Symposium. So compared to photon techniques, protons have very good normal tissue sparing and less complications, especially after immediate breast reconstruction. This is the rationale behind proton post-mastectomy radiotherapy. And hypofractionation in protons can reduce the cost and improve access. Patients above the age of 18 years who underwent mastectomy and axillary staging were included. The primary objective was a 24-month complication rate of grade 3 or higher adverse events or any unplanned surgical interventions. 88 patients were randomized into 2 arms. The first arm was conventional fractionation with 25 fractions, and the second arm was hypofractionation with 15 fractions, 41 patients in each arms. Similar rates of complications, 6 patients in the conventional arm and 8 patients in the hypofractionation arm, but this was not significant. Dosimetric parameters were favorable in both, but specifically the ipsilateral lung V20 dose percentage was 8.6, that is very less in the 15 fractions arm. There were no locoregional recurrences in both arms. So to conclude, this is the proton post-mastectomy radiotherapy provides excellent locoregional control and normal tissue sparing. Complication rates are similar in both arms, but this study could not prove the non-inferiority of proton hypofractionation, probably because of a small sample size. And we require further studies on optimal dose and fractionation for proton PMRT. We all know that in the past couple of decades, there has been a trend towards hypofractionation in photon techniques. Hypofraction is basically bigger doses per fraction and shorter duration. But I think the same data from photons cannot be extrapolated into proton therapy because they have different physical characteristics and radiobiology. Yes, the doses to normal structures are significantly less, but whether this translates into better oncological outcomes, that needs to be studied further. Thank you.